You know that feeling when a Charlie horse suddenly rips through your calf? It's it's this blinding, seizing, utterly localized pain.
Oh, yeah, where you just drop whatever you're doing.
Exactly. You grab your leg, you dig your thumbs into the muscle, and you stretch it out, and the cramp eventually yields. But uh, imagine for a second that you get a muscle cramp with that exact same intensity, but it happens deep inside your core.
Right, in a place you literally cannot reach.
You can't massage it. You can't even see it. And worse, it doesn't just last for a few excruciating minutes. It lasts for months, sometimes even years.
It becomes this persistent, invisible weight. And,
Huh.
because you can't point to a bruise or put it in a cast, it's incredibly difficult to explain the sheer exhaustion of it. You're living with a muscle that is continuously burning fuel and sending alarm signals to your brain 24 hours a day.
And we're talking about the pelvic floor. So today's deep dive is pulling together medical literature, physical therapy guidelines, and clinical studies. We're focusing on a highly complex part of human anatomy that handles a massive mechanical and psychological load for you, yet it rarely gets discussed openly.
Yeah, it's a topic with a lot of stigma, unfortunately.
It really is. And our mission today is to explore a fascinating medical crossover that deals directly with those persistent cramps. We're looking at how Botox, the very same wrinkle smoother used in dermatology, is being deployed to treat chronic pelvic pain and severe muscle spasms.
Which sounds completely wild at first, right? Using a cosmetic toxin for deep pelvic pain.
Right. But the core question driving this whole exploration is a mechanical puzzle. If we use a paralytic neurotoxin to relax a completely tightened pelvic floor, do we accidentally create the exact opposite problem? Are we risking laxity symptoms?
Like urinary incontinence or organ prolapse.
Exactly. Are we causing those issues by paralyzing the very muscles meant to hold everything up?
It is a profound physiological tightrope walk. You have a patient suffering from extreme tension, and to solve it, you have to carefully introduce weakness.
Okay, let's unpack this. Because before we can even begin to understand what injecting a neurotoxin into the pelvis actually does, we have to understand the daily mechanics of these muscles. What are they actually doing for you?
Well, to visualize the pelvic floor, think of a muscular trampoline. It stretches right across the bottom opening of your bony pelvis. It attaches from the pubic bone in the front, sweeps all the way back to the tailbone, and extends side to side between your sitting bones.
So it is a dynamic, load-bearing web of tissue. It's not just a static shelf.
Far from it. It has a really heavy job. It's holding up the bladder, the bowel, and in women, the uterus.
So every time you cough or jump or lift something heavy,
Right.
that trampoline has to absorb the downward pressure, right?
Right.
Just to make sure those internal organs don't drop.
Precisely. But here's the critical design feature. It's a trampoline with holes in it. It has passages that allow the urethra, the vagina, and the anus to pass through.
Right, which means the normal, healthy function of this system requires rhythm and flexibility.
Exactly. The muscles need to tighten and wrap firmly around these openings to maintain continence. When you feel a sudden urge to use the restroom but you're stuck in traffic, that is your pelvic floor actively contracting. It's kinking the hose, so to speak, to hold everything in.
An absolutely vital function for getting through the day. But the other half of that rhythm is that they have to be able to completely let go.
They do, to allow for urination, passing a bowel movement, or for pain-free sexual intimacy. Those muscles have to yield.
And the problem we're looking at today is pelvic floor hypertonicity. The muscles get stuck in the contracted position. They act like that persistent calf cramp we mentioned, completely locked up.
And how a person ends up with hypertonicity is rarely as simple as a direct blunt force injury. A lot of it actually stems from repetitive behavioral patterns.
Like what? What kind of patterns?
Take something called deferred voiding. This happens when you feel the biological urge to urinate, but you suppress it because you're busy at work, or maybe you only feel comfortable using your own bathroom at home.
Oh, wow. So you just hold it for hours.
Yeah. Your brain commands the pelvic floor to maintain a high alert, high tension state for hours on end, completely overriding the bladder's natural signals.
The clinical literature also points out something called hover peeing, which is such a specific but common habit. I mean, you see this all the time.
Oh, absolutely. It's incredibly common.
When you squat or hover over a public toilet seat because you don't want to touch it, you are actively engaging your core and your pelvic floor to hold that awkward isometric squat.
Right. So the muscles never get the green light to fully relax. You're basically forcing the bladder to push urine out against a closed door, which creates immense strain on the whole system.
Do that enough times, and the nervous system starts to adopt that heightened state of tension as the new normal baseline.
Then you add in the psychological component, which is often referred to in the literature as the primitive stress response. Neurologically, when we experience stress, our bodies still react as if we are facing a physical predator.
The tailbone tuck. I read through this mechanism in our sources, and the biomechanics are just fascinating.
It really is. Explain how that works.
Well, if a predator is attacking, the body instinctively curls inward, right, to protect the soft, vital organs of the abdomen and pelvis. So the tailbone slightly tucks underneath.
Exactly. You might just be stressed about, a mortgage payment or an argument with a friend, but your subconscious enacts that exact same subtle guarding mechanism.
You carry your anxiety right in your pelvic floor, constantly shortening those muscles without even noticing it. It's a low-grade, constant clench.
So it's like a fist that you've held tightly for years. Eventually, the brain and the tissues forget what an open hand even feels like. The muscle loses its elasticity entirely.
And the result of that clenched fist is a brutal pain spasm cycle. The muscle is tight, so it hurts. Because it hurts, your brain senses danger and triggers protective muscle guarding,
Right, it's bracing against the pain.
which causes even more tightness.
Yeah.
And that cuts off blood flow, which causes more pain. It's a relentless loop.
There is a physiological metric in the studies that really illustrates the severity of this. Just a 10% contraction of these pelvic floor muscles reduces blood and oxygen flow to the surrounding tissue by 50%.
Wait, really? Half of the oxygen supply gone just from a 10% contraction?
Yes, just from a subtle, barely noticeable background tension. And that lack of oxygen localized ischemia creates an acidic, inflammatory environment within the tissue.
So the muscle fibers are basically suffocating in their own metabolic waste.
Exactly. And that irritates the nerves and makes the cramps significantly worse.
Which leads to a really obvious mechanical question.
Yeah.
If the problem is just a tight, clenched muscle, isn't physical therapy the standard fix?
You'd think so, yes.
You go to a pelvic floor physical therapist, they manually release the trigger points, you do some deep breathing, you stretch it out. Why doesn't that work for everyone?
Because eventually the muscle isn't just tight. The nervous system has designated it as a strict no-touch zone.
Ah, so the brain is protecting it.
Yes. When the brain has spent years associating completely normal movements like sitting down, having a full bladder, or attempting intimacy with severe pain, it puts up a neuromuscular firewall.
So physical therapy just bounces right off it.
For many patients, traditional physical therapy can't break through because the patient is in too much agony to even tolerate the internal manual therapy required to stretch the tissue. The body violently guards against the therapist's intervention.
You just hit a brick wall of pain. And that is exactly where Botox enters the clinical picture. We need a way to force the muscle to drop the firewall, like a neurological override.
What's fascinating here is how Botox, or onabotulinum toxin A, actually achieves this. We have to look at the neuromuscular junction, the exact point where a nerve ending meets a muscle fiber.
Okay, the connection point.
Right. Normally, when your brain wants a muscle to contract, the nerve releases a chemical messenger called acetylcholine. Acetylcholine crosses the gap, binds to the muscle, and sparks the contraction.
So acetylcholine is basically the spark plug. The brain turns the key, the spark plug fires, the engine revs, and the muscle clenches.
Perfect analogy. Botox works by physically entering the nerve ending and destroying the proteins responsible for releasing that acetylcholine.
Oh, wow. So it unplugs the spark plug entirely.
Exactly. The brain can be turning the key frantically, screaming at the muscle to spasm, but because there is no chemical spark, the muscle remains completely still. It forces the cramp to release.
That's incredible.
But Botox also has a secondary, highly beneficial mechanism for chronic pain patients. It actually blocks the release of inflammatory neuropeptides.
What are those?
These are the chemicals that transmit pain signals from the tissue back up to the brain. By blocking them, you are effectively turning down the volume on the localized pain.
So it's not just a muscle relaxer. It actively dampens the pain feedback loop itself.
Yes, it tackles both the spasm and the pain signaling. And the way specialists administer this is highly targeted. It's usually a quick outpatient procedure.
The sources mentioned the doctor injects anywhere from 40 to 400 units of Botox directly into the spasming muscles. But because they can't always just look and see which deep pelvic muscle is causing the problem, they use EMG guidance.
Electromyography, right?
Right. And the way this works is brilliant. They use a specialized needle that acts almost like a microscopic microphone, and it's listening for electrical activity.
Because a healthy resting muscle is quiet.
Exactly. But a muscle locked in a hypertonic spasm is constantly firing electrical signals. Through the EMG monitor, The doctor can literally hear the spasm as this angry, crackling static.
That's such a visceral way to diagnose it.
They move the needle until the static is loudest, and that's how they know exactly where to deploy the Botox. They target specific muscles like the pubococcygeus or the puborectalis.
The pubococcygeus is the main hammock supporting the pelvic organs, and the puborectalis forms a literal sling around the rectum, kinking it forward to maintain bowel control.
And this brings us right to the core focus of our deep dive. This is the mechanical paradox.
The big question.
Right. If the pubococcygeus is the hammock holding up the bladder and the uterus, and the puborectalis is the sling keeping the rectum closed, and Botox works by paralyzing muscles, aren't we risking the whole floor collapsing? Does treating a tight pelvic floor with Botox cause laxity symptoms?
It's the most critical question a patient can ask. To cure the hypertonicity, the extreme painful tightness, we are intentionally pushing the musculoskeletal system toward hypotonicity. We are inducing weakness.
And what does that weakness actually translate to in your daily life? We're talking about laxity symptoms. That means pelvic organ prolapse where the support structures fail and the bladder, rectum, or uterus physically drop down into the vaginal canal.
It also means incontinence, the inability to control urine or stool.
So do patients trade their severe pelvic pain for incontinence and prolapse?
The mechanical reality is yes, they can. When you inject a paralytic neurotoxin into the exact muscles responsible for keeping the urethra and the anus closed, the potential side effects are a direct reflection of that paralysis.
So the clinical data explicitly lists urinary stress incontinence, fecal incontinence, incomplete bowel emptying, and urinary retention as known risks.
If we connect this to the bigger picture, you are intentionally turning off the security system. If you paralyze the puborectalis sling, it can no longer kink the hose.
So leaking isn't some mysterious random side effect. It is the direct physical consequence of the muscle being turned off. You're essentially trading a debilitating, chronic, painful muscle spasm for a temporary case of incontinence.
It is a deliberate trade-off, and the dosage plays a massive role here.
How so?
The literature notes that injecting higher doses, particularly anything over 100 units into these specific support muscles, carries a significantly higher risk of causing that urinary and fecal incontinence.
So the doctor has to find the exact threshold where the spasm releases, but the structural integrity of the trampoline isn't completely compromised.
Exactly. It's a very fine line to walk. But there is a massive reassurance built into this treatment, which is the lifespan of the medication itself.
Right, because these laxity side effects are self-limiting. Botox does not cause permanent paralysis.
Correct. The nerve endings eventually sprout new connections. So any induced laxity, prolapse sensation, or incontinence typically resolves entirely on its own as the medication naturally wears off over 3 to 6 months.
The muscle function just returns.
It does, which is why the location of the injection is the defining factor in what symptoms you experience. We've established that injecting Botox into the structural pelvic floor muscles can cause incontinence by weakening the sphincter. But it's vital to note that injecting Botox directly into the bladder muscle itself, the detrusor, is an FDA-approved treatment to achieve the exact opposite result. It actually stops incontinence.
Here's where it gets really interesting, because that distinction blew my mind when I was reading the urology guidelines. It sounds completely contradictory until you look at the mechanics.
It's all about what the specific muscle does.
Right. If you have an overactive bladder, your bladder muscle is the one spasming, squeezing urine out against your will. Injecting Botox into the wall of the bladder paralyzes that specific squeezing action, stopping the leaks.
But if your incontinence is caused by a weak pelvic floor that fails to hold the exit door shut, paralyzing the pelvic floor further will only make the leaking worse.
The exact same medication, applied to a muscle just a few inches away, produces a completely opposite outcome based entirely on the biomechanics of that specific tissue.
It's all about whether you are paralyzing the pump or paralyzing the valve.
So bring it back to pelvic pain. If the effects only last 3 to 6 months, and it carries this very real risk of temporary laxity, leaking urine, or feeling like your organs are heavy and dropping, why do it?
It's a fair question.
Why undergo an invasive procedure just for temporary relief that might introduce a new, completely embarrassing problem?
Because the Botox itself is not the cure. The goal is not to create a permanent state of weakness. The goal is to pry open a window of opportunity.
A window for what?
Well, Botox does not lengthen muscle fibers long term, and it does not fix the underlying postural or behavioral dysfunctions that cause the hypertonicity in the first place. What it does is force the spasm to yield long enough for the actual cure to take place.
Okay, so it buys you 3 to 6 months of profound relaxation.
Yes. And during this window, the patient engages in intensive pelvic floor physical therapy.
Because before the injection, the muscles were an impenetrable wall of guarding.
Exactly. But now, with the muscle chemically forced to relax and the inflammatory cane signals muted by the blocked neuropeptides, the physical therapist can finally manipulate the tissue. They can manually stretch the pelvic floor.
And the patient can use vaginal dilators at home without excruciating pain.
Right. And they can finally address the systemic, full-body mechanics that feed into pelvic pain, like breathing.
The relationship between the diaphragm and the pelvic floor is essentially a piston system, right?
That's a great way to visualize it, yeah. Your rib cage and your pelvis should be stacked. When you inhale deeply, your diaphragm, the large muscle under your lungs, pushes down into your abdominal cavity.
And to accommodate that downward pressure, your pelvic floor must naturally yield and stretch downwards.
Yes. And when you exhale, the diaphragm moves up and the pelvic floor recoils back up.
But if your pelvic floor is frozen in a spasm, it refuses to drop. The pressure has nowhere to go.
Exactly. So the patient unconsciously stops taking deep breaths and becomes a shallow chest breather, which only heightens the nervous system's stress response.
Botox chemically forces the pelvic floor to drop, which allows the physical therapist to reteach the patient's body how to breathe biomechanically correctly again.
And that physical retraining happens concurrently with psychological retraining. We really cannot overstate the psychological burden of chronic pelvic pain.
It severely isolates people.
It does. It creates conditions like dyspareunia, which is severe pain during sex, or vaginismus, where the vaginal muscles involuntarily snap shut at any attempt at penetration. It creates terrible anxiety around simple biological functions like having a bowel movement.
The brain learns a Pavlovian response. Intimacy equals pain. The bathroom equals pain. So the nervous system automatically triggers a defensive spasm before the activity even begins.
Exactly. The brain is trying to protect you, but during the 3 to 6 month Botox window, you remove the pain from that equation.
Which is huge.
This is where cognitive behavioral therapy and psychosexual therapy become incredibly effective. A patient can attempt intercourse, or use a tampon, or simply sit comfortably in a chair for an hour and experience zero pain.
And when that happens, the brain gets confused in the best possible way. The alarm bells just don't ring, the threat doesn't materialize.
You are utilizing neuroplasticity, the brain's ability to rewire itself based on new experiences. Every time the patient engages in those activities, pain-free during the Botox window, the brain weakens the neural pathways that associate those actions with danger.
The nervous system recalibrates. It unlearns the fear response.
That is the true value of the neurotoxin. If you inject Botox but skip the physical therapy and the cognitive behavioral therapy, you haven't solved the root cause.
Right, because the moment the medication wears off and the acetylcholine starts firing again, the brain will immediately resume its defensive posture. The muscles will snap right back into their painful spasm.
Exactly. Botox is just the scaffolding. It holds the walls up and keeps the rain out just long enough for you to pour a new foundation.
It interrupts a closed-loop system of dysfunction.
It really does.
So what does this all mean? To synthesize everything we've explored today around our core mechanical question, can using a paralytic toxin to treat pelvic floor spasms cause laxity symptoms?
The clinical reality is undeniably yes.
By paralyzing the muscular trampoline to force it to release a chronic cramp, you can temporarily experience weakness, urinary or fecal incontinence, and the sensation of organ prolapse.
But that controlled temporary laxity is often the precise, necessary intervention required to break a years-long cycle of pain.
You strategically endure a temporary mechanical weakness to buy the time needed to gain a permanent release from the nervous system's high-alert spasm.
And looking at the sheer volume of literature on how these spasms develop, it forces a broader reflection on our modern environment.
Yeah, we've traced severe pelvic tension back to psychological stress, to our desk-bound postures, to rushing through our days and suppressing natural urges like a simple bathroom break.
The tailbone tucking against a perceived predator that is actually just an overflowing inbox.
We are storing our daily low-grade panic in a complex web of muscles we can't even see.
Which raises a profound point for you to think about. If our environments and our habits are driving our nervous systems to lock our bodies into such extreme defensive postures that we require a potent lab-synthesized neurotoxin just to force our own muscles to let their guard down,
Right.
what does that say about how safe we actually feel moving through our daily lives? And more importantly, beyond the scope of a medical procedure, what changes would it actually take to teach our bodies that it is safe to finally let go?
Are we listening to what our physical tension is trying to tell us about our environment? It's a fascinating lens to view our own anatomy through. Thank you for joining us on this deep dive. Keep questioning the mechanics of the world around you, keep exploring, and remember to occasionally take a deep breath, let the diaphragm drop, and consciously let that invisible tension unclench. We'll catch you on the next one.